All right, good evening to all of our listeners out there. My name is Tejas Shah. I am a member of the Public Affairs Committee here at the North American Spine Society, PM&R resident, PGY2 here at Penn Medicine in Philadelphia, Pennsylvania. This is the next installment of our podcast where we showcase interesting articles from all around the country. We have one of the authors of this next article we're going to listen to here. You'll be hearing from Claus. He's a key author for the paper that we're going to discuss, which is entitled The Effect of Ketorolac on Posterior Minimally Invasive Transforaminal Lumbar Interbody Fusion, an interim analysis from a randomized, double-blinded, placebo-controlled trial. I want to go and first let Dr. Claus here introduce himself, but I do want to say that I went to Beaumont Medical School in Michigan, so we are sort of connected there geographically. So go ahead, Dr. Claus.
Wonderful. Thank you for having me. It's a pleasure. So I'm currently a 6th-year neurosurgery resident at Michigan State University with Ascension Providence Hospital here in Detroit, Michigan. So I'll be finishing up here in a year or so.
Oh, fantastic! Yeah, and Michigan is a fantastic place. I'm actually originally from Southern California myself. Did you grow up in Michigan? And just tell us a little bit about what got you interested in neurosurgery to do your residency.
Sure. Yeah, no, so Detroit is new to me, or at least prior to this. I'm originally from Las Vegas, Nevada. I grew up there pretty much my entire life. My father's a veterinarian and my mother's a nurse. So as you can imagine, my interest in medicine came quite natural from that. As far as neurosurgery, for whatever reason, I was just always fascinated with the brain and any brain topics. And I think I was in high school. I came across the book. It's titled "When the Air Hits the Brain" by Frank Vertosik. I think he went to probably Pitt, if I remember correctly. But he really describes a very interesting and easy read about going through neurosurgery residency and the type of patients and pathology. So it's very interesting, and ever since then, I've been hooked.
Interesting. Yeah, I always find it really interesting how people get interested in their fields, whether they want to do it from as when they were little or something they kind of found in medical school. That'd probably be the story for myself finding PM&R, because I didn't really know what it was till I went there. So it's great to hear that. Now, before we sort of get into the article, I just want to, for our listeners out there, especially not from the neurosurgery world or even the orthopedic surgery world, can you just describe this procedure, minimally invasive transforaminal lumbar interbody fusion? I would say probably from how it was done previously and then the minimally invasive impact of it. I think if you can just give a brief overview, that'd be great.
Yeah, sure. So, there are a number of ways to achieve, if you want to say, a lumbar fusion. There are a number of reasons to have a lumbar fusion, but there are a number of ways to achieve it. You can either come from the front, you can come from the side, you can come from the back. And so the transforaminal lumbar interbody fusion is from the back, from a transforaminal approach. And the minimally invasive technique, there are a number of different techniques that are described, quote unquote, minimally invasive. But as far as our technique at our institution, typically involves the use of a 20 to 24 millimeter tubular retractor system that we use for the entirety of the surgery, for the most part, for the decompression of the spinal elements, for the actual interbody fusion, and then as well as the placements of all the pedicle screws. Those are also done percutaneously. So historically, and it's still very commonly done today is a more of an open approach where you do a midline incision, open up the spine, dissect all the muscle off the spine, and try to achieve the same results. So we've tweaked that a little bit in some of our techniques, and our incisions are much smaller, obviously, and more of a paramedian location than historically done from the open approach.
Awesome. It's fantastic. And it's glad to see the minimally invasive approach in so many different aspects of surgery, whether it's orthopedic, neurosurgery, urology, general surgery, et cetera. I think it's fantastic for the patients too. So it's great to see how that's going to go down the road. I'm used to, BNP as like the, BNP panel we get every morning to check the sodium and chloride. So when I saw the BNP in your paper, I had to kind of look that up. I understand the bone morphogenetic protein is more of an emerging thing that's being used with these types of surgery. Can you just give a brief introduction and an overview of that as well for our audience?
Sure. So yes, as you said, BMP stands for bone morphogenic protein, and what it is, it's a recombinant human growth factor that's responsible for bone growth. And it's been around for some time now, and it's found a role as a nice adjuvant to either allograft bone or even in some regard replacement for harvested autograft to help improve achieving that bony fusion. In particular for MIS fusion, compared to the big open where you open and dissect all the muscles off the spine, you have a lot of surface area in the posterior lateral area to put bone graft and really put down a robust effort to achieve fusion. Well, with the minimally invasive technique, we really don't have as much of that surface area to work with, and so it's a little bit more limited. So at least at our institution, we found that the use of BMP in the minimally invasive technique has really helped augment our fusion capabilities and improve our fusion rates.
Okay, great. That's fantastic to hear. We heard a little bit earlier about your interest in sort of neurosurgery, but I'm also interested in kind of what got you interested in this specific topic, whether it's something, you've noticed in patients that you've, operated with when you were a med student versus when you're a resident. What really kind of brought your attention to this topic?
I think if you ask any spine surgeon, they can really attest to the amount of pain that these particular patients endure after lumbar fusion. It's probably one of the most painful procedures that we do. And so, as spine surgeon, I think we're always looking for options to help with it that don't involve using opioid medications. And prior to this study, anecdotally, we would use it sparingly here and there. And what we experienced a lot of success using Ketorolac in regards to pain control, but also surprisingly, we noticed a tremendous decrease in the opioid consumption by the patient. They just didn't need it as much. But since there historically have been a lot of concerns with using NSAIDs, particularly Ketorolac, with fusion and its risk with non-union or pseudoarthrosis. So we thought it'd be a great idea to try to see if we can replicate those results in a more controlled, standardized fashion, and really see if it actually impacts fusion rates.
Yeah, and I think you certainly don't even have to be in the medical world now with how much attention there is to the narcotic use and opioid consumption. And I do like that, being personally interested in pain management, to find ways to have, to get patients sort of off, relying on opioids. I know at the Penn Rehab Hospital, we get a lot of patients after, back surgeries, a lot of laminectomies and fusions. And so a lot of them come in with, taking 15 oxycodone, Q6, and even that's not enough for them. So I think it's fantastic that, we can find another medication and kind of help, relieve some of the emerging doubts of it. That's maybe more outdated, so to speak. You kind of touched on some of the issues, I guess, for my next question and the previous answer you provided in terms of like for this specific surgery as opposed to other back surgeries. I guess we can stay in that realm. Where does it really rank for you in terms of like, post-operative pain that patients have, how much they stay? Maybe a very difficult question to answer because every patient's different, case by case, right? Every case is different. So is there any like general overview you can provide on that front?
Yeah, like I said, I think, if in general, I think the lumbar fusion procedure itself is probably one of the more painful procedures, if not the most painful procedure. Just a lot of work that goes into it that perhaps you may not notice, as a patient, based on the size of the incision or, based on the amount of time that, the surgery take. But there's a lot of work that goes into it, and with that comes a lot of pain. And like you said, every patient is different, whether they've been on opioids prior to it, for how long, what type of opioids, and that certainly affects their ability to be able to control their pain post-operatively. Since we for the most part, we do just about every lumbar surgery through a minimally invasive technique. And so that really is, we've really seen the benefit in that, whether it's regarding length of stay, the postoperative complications. Most of our patients are typically home within the next day or two. They don't stay a whole lot in the hospital, and I don't know if that has to do with the minimally invasive technique itself. I think here we do a very good job of really taking the whole picture, whether not just necessarily pain, but trying to prevent complications. It starts with things like ambulating them within 6 hours after surgery, and implementing a multidisciplinary approach, and a lot of things into it. So that probably plays a lot into it as well. But I think there clearly are benefits to the minimally invasive as far as complication. I think there's a lower risk of postoperative infection. If they're going home sooner, they're ambulating sooner because their pain's a little bit less. They're less risk for thromboembolic events, DVTs, PEs, and so forth.
Yeah, fantastic. Yeah, and you definitely hit the nail on that one, because from a physiatrist perspective, hearing about ambulating soon and multidisciplinary approach is definitely pearls to my ear, so to speak. So I appreciate you bringing it. It's very important, because when you get patients moving earlier, the better it is. And
right.
I think too many times, sir, maybe patients think it's kind of like you taking your car to a mechanic. You just get it fixed and then you go. There's no really rehabbing a car, so to speak. But human body's a little different compared to that. You also touched on this as well prior to that, but I also kind of wanted to expand, if you can, on Toradol, which is an NSAID, like you mentioned. For all the listeners that may not know, NSAID is non-steroidal anti-inflammatory medication, same class as an aspirin, ibuprofen, though it's a little bit more potent. We certainly know, as in the medical realm, as medical students, medical residents, about the key side effects that we would get quizzed on, tested on, in terms of GI bleeding, kidney dysfunction. From a neurosurgical perspective, what tends to give more neurosurgeons pause about using a medication like Toradol? You touched on pseudoarthrosis. If you can just maybe expand on that as well.
Yeah. So I think when using any NSAID, not just Ketorolac, but especially in the immediate postoperative period, I think anybody's immediate concern is going to be really related to the potential bleeding risks that NSAIDs have, and due to their effect on platelet function. So particularly with spine surgery, that becomes quite concerning, following any decompression of the spinal canal or whatnot, because any even small amount of blood can lead to an epidural hematoma, and this can often be an emergency. So that is probably the immediate concern with using something that may have some thinning or blood thinning effect. And then the other one that we touched on also is its particular effect or potential effect on spinal fusion, and using it in that sense. Just to put it, when we're trying to achieve spinal fusion, we rely on the natural process of bone healing, which is, to put it simply, an inflammatory process. And then by using NSAIDs that are anti-inflammatory by nature, it kind of makes it counterintuitive or counterproductive in that sense. But what we found is that if you use it for a short period of time in a low dose manner, it appears that there's really no impact or a negligible effect on fusion.
Yeah, no, exactly. And then that was really fantastic to see as well. For your study, we had the control population that was given saline in place of the Ketorolac medication. Can you just go over briefly for patients, our audience that may not be familiar, what was the typical pain regimen they received as opposed to their Toradol or Ketorolac counterparts?
Yeah, so our aim for this study was really to try to control and standardize as much as possible in this study. We really wanted to optimize the internal validity of our main questions that we were trying to answer. So both groups, the control and the Ketorolac group, both received the very same standardized pain regimen. This included an oral narcotic that they would receive as needed for their pain every 4 hours. They also received an IV opioid medication that they received every 3 hours as needed if they needed it. And then in addition, they also had an antispasmodic as well as needed. But the amount that they took was really at the discretion of the patient and their pain. And because the entire treatment team, the APPs, the residents, and everyone was blinded to their allocation. So there was really no influence on them. If they needed more pain medication, the protocol allowed them to have more. If they didn't need it, then they didn't take it. So it allowed us to really get an idea of the amount of opioid that they're taking, hopefully in response to receiving or not receiving Ketorolac.
Okay, thank you for clarifying that. And then, also just wanted to add on, if you can just briefly summarize the key takeaway points of the paper. And I do also want to mention, if it hasn't been mentioned before, this paper did win the 2021 Outstanding Paper Award as well. So take it away.
So this was an interim analysis. This was a planned interim analysis where we reached our midway point in our study. And so what we looked at, the patients that received Ketorolac, they received it for 48 hours, about every 6 hours for that 48 hours, and the control group received just a placebo or normal saline in the same manner. And our primary outcome was fusion. Our main question was, well, does this affect fusion? Because if it does, regardless if it limits our opioid use or their patients are out of the hospital sooner, it really doesn't matter if it still has an impact on fusion. So that was our main question we answered. But what we found is that not only did it significantly decrease their opioid consumption, it achieved this all while maintaining their same pain score. So we also looked at their pain scores and said, well, maybe they took less opioids and they were in more pain, but in fact they were both equal. So they both achieved about the same amount of pain scores throughout the time that they were taking the Ketorolac or the placebo, and saw a significant decrease in their opioid consumption. This group that received Ketorolac also saw a significant decrease in their length of stay. And then looking at their postoperative imaging at 6 months and 1 year with dynamic x-rays looking at fusion that was done by a blinded neuroradiologist, found no statistically significant difference between the two groups at both 6 months and 1 year, and certainly did not reach a margin of inferiority, which was our study design.
Exactly, and that's fantastic to see. And when you describe the margin of inferiority, can you just go over sort of that term as well for our audience, just so they're aware whenever you are trying to entertain an idea of using a better medication, really what that sort of means for us from a statistical perspective?
Yeah, to put it simply, you can think of it in 3 different ways. So when looking at, like, if we were coming up with a new drug, we typically like to do that in a superiority manner, meaning if I'm going to come out with a new drug, I want to see if it's actually superior to X drug or the previous drug that's on the market. That's one way to look at one method to look at a study. There's equivalency to say that, well, our technique or our drug is equivalent or no worse than what's available. And then from an inferiority, especially looking at fusion specifically, we want to ask, well, is what we're giving them, Ketorolac, is that going to result in an inferior fusion rates compared to not giving them Ketorolac? Because we know it's, you could arguably do an equivalency study, but you certainly aren't going to do a superiority. It's really, does this have an effect so large on the fusion rate that it's obviously or statistically inferior to not giving that? And you set a margin, what you would expect to be, or what would be, so you could say that whether spine surgeons or the community would say is acceptable. If your fusion rate, let's say our fusion rate is 90%, we can accept a decrease in 5% or even, let's say, 10%. We can accept that decrease in fusion rate. That's reasonable. So putting that margin and saying, well, what's not acceptable when saying if this is going to affect our fusion rates, if it drops below 15%, that's not acceptable. This is something that is probably more deleterious and more harmful than not giving it.
Oh, fantastic. I love the way you describe that. An example is good, because we're essentially, for any medication that we give or for any procedure that we do, we're essentially just looking for the benefits and the risks. So I can understand that when you describe it, it's how much can we tolerate for this inferiority to occur while still obviously providing the benefits of decreased length of stay, better pain control, less reliance on opioids. So appreciate that. And I think our listeners, especially the ones that are statistically naive, will appreciate that as well. Thanks for doing that. That was fantastic. I do want to go back to something we kind of touched on before, which is the BMP, or bone morphogenic protein. You mentioned that it's becoming really used more and more in most of the studies that are going on. Are there, from your experience or from what you've read in literature, are there any sort of drawbacks to using BMP, or any particular procedures maybe that many surgeons would not feel comfortable using it?
Yeah, so the use of BMP has been around for some time. I think the true FDA indication or allowance of use of BMP was approved for the anterior lumbar interbody fusion, and there's a lot of studies that came out a long time ago with a lot of limitations and a lot of criticism and controversy. So a lot of it is many people use it in a more quote unquote off-label use if it's not done in the anterior, although it's a similar procedure in the sense of the actual interbody fusion itself. I think the biggest drawback to using BMP, or perhaps the surgeon might be hesitant in using it, is probably the cost. It's not cheap. So if you're someone that can reliably get a very high fusion rate with your technique that you're doing, or with for whatever reason, certainly I think a cost component may be relevant. The other concern too is that because it is a bone growth factor, it can grow bone. So if it's not placed in the right area, theoretically you can get heterotopic bone formation in areas that you don't want to have bone growth, whether that's in the foramen, or in the lateral recess of the spine. If you don't put it in the correct area, you can certainly have a heterotopic bone formation that can be troublesome, can cause a radiculopathy or issues there. I think the other more common thing is probably a radiculitis. It is a pro-inflammatory drug. So even if it's not near the nerves, there is a well-described phenomenon of radiculitis after the use of BMP. So those are probably the three main ones that I can think of off the top of my head.
Oh yeah, no, it's very interesting, and yeah, I can definitely understand how if increased bone can impinge on the spinal canal, and that can cause lumbar stenosis, which can, as you mentioned, lead to radiculopathy, cervical radiculopathy, etc. So yeah, something to definitely be mindful of. The key takeaway point I would say from your study was really the focus of Ketorolac. Do you feel, however, just to kind of go over once more the topic of BMP, that's going to get used more and more, and the harmful effects that you mentioned maybe kind of maybe put aside just because of how maybe helpful it may be in surgery, or not? What are your opinions on that?
Well, I mean, since it's been around for some time, I think people who use it or don't use it are pretty set in why and reasons. Maybe perhaps things they might shift one way or the other. I don't necessarily think that this particular study would encourage or even discourage anyone from using it. However, it may encourage someone to use it if they were going to transition to utilizing Ketorolac on a more regular basis postoperatively for their pain control, in the same manner that we did. Just because I think the big limitation here in our study is that it's unclear that if perhaps the use of BMP itself will masks the potential inhibitory effect of Ketorolac, and so that maybe in the absence of BMP use, you might actually see deleterious effect of Ketorolac without that. So it's unclear. So that might push someone to use BMP if they were really set on implementing a Ketorolac in a postoperative pain regimen.
Interesting. Yeah, and it certainly could spawn some further areas of research. Who knows?
Right.
Yeah, and one of the limitations to your study, to many studies across the world probably, was the COVID pandemic that we're still living through right now. We're in the Omicron variant, and hopefully when people are listening to, we obviously hope everybody's doing well and everybody's family is safe at this time. Particularly when it comes to this procedure, which I believe is elective, how would you describe the impact that it had in terms of recruitment, follow-up for these patients? et cetera. If you can just maybe comment on that, and if that prolonged your data collecting period and all that.
Absolutely. Yeah. Like many hospitals, around the country, we too got hit pretty hard with the pandemic. Early on in that spring of 2020 into the summer, there was a good month or two, maybe even almost 3 months where elective cases were either completely canceled or partially. There were some exceptions that were kind of loosened as time went on. So that really put a damper in that just to begin with. So there was a 3-month period of really not being able to do anything, even if we wanted to. But then once we returned to elective cases, even though it was limited, we were still able to do it. The problem came that we saw is that a lot of the interaction with the patient was done via telemedicine, and I think we found it was much more difficult to get patients to participate in studies. They were a little bit more hesitant to get involved just by discussing over the phone or even on Zoom. So that was also affected our ability to recruit at that time. And then even those that were recruited or were had surgery prior to the pandemic, it became very difficult for these people to want to come back and follow up. We certainly can do telemedicine visits for normal patient reported outcomes and measures like that. But as far as coming back to the clinic or the hospital to get postoperative x-rays and imaging, patients were very, very hesitant in coming back. So that would also pose a very large problem. And then to add insult to injury, getting the drug itself, Ketorolac, became a problem and still is a problem today. It's been affected by the supply chain issue. So have been dealing with and are currently still dealing with a prolonged shortage of the medication as well. So all these factors have really dampened our ability to complete this trial, in the time frame that we were hoping, unfortunately.
Wow, yeah. I was probably expecting some of what you said, but then the Ketorolac supply chain, I think that definitely surprised me. I mean, there's a supply issue from all different areas, and to see that is definitely concerning. And again, I think I started my residency in the pandemic. I graduated in the pandemic, and hopefully, down the road, things can shore up and we can go back to normal as possible. But certainly something that, who knows? I mean, this will be a proving point down the line, and I don't think any study can be as difficult when it comes to recruitment when you've had to deal with the pandemic. So I'm glad that you were able to. Yeah, I'm glad you and your team were able to obviously collect the data and get this paper in. One aspect of research that's very important that I know I've been taught is always about, what's next, what's the next thing, how do we expand on this? How do we build on this? And so from your perspective, and you are, in the neurosurgery field, what do you want to take away from this? How do you think this can be, extrapolated, like the use of Toradol? Can it go into different aspects of surgery? Maybe you can't comment on general or urology surgery, but can you comment on different types of neurosurgery? And are there any neurosurgeries that you don't think Ketorolac would be a good benefit for? So what are your hopes for this study to will open the doors to? What I'm trying to say.
Yeah, I think first it would probably open up, or maybe perhaps inspire a little bit of an open mind as far as exploring other options to get rid of opioids. I don't think there's really just not a whole lot of benefit to opioids that we can really see these days. And unfortunately, for a lot of maybe not for a lot of brain surgery, but certainly for a lot of the spine surgeries, opioids is really still a main component of that. And there's been a lot of good ideas, and a lot of groups and institutions have really worked on the ERAS protocols, or this enhanced recovery after surgery protocols, and they've made a real good headway, and I think that is probably going to be the future. And I think if we can add things to those protocols like Ketorolac, I think we can only make it better. I think it's certainly reasonable to expand even the use of NSAIDs or Ketorolac even into the brain surgery realm as far as controlling pain, although postoperative pain isn't really that big of a problem compared to spine, surprisingly. But the problem is the bleeding risk, and I think it's a real concern and a reasonable concern, and to be hesitant with trying something like that we know affects platelet function. And if patients aren't in that whole lot of pain to begin with, I can't blame any neurosurgeon for not wanting to take the risk with using NSAIDs for that. But I certainly think adding Ketorolac to an ERAS type protocol and expanding it in that realm, and perhaps finding other modalities to add to it, I hope will be the future. I think it will be the future.
Fantastic. Yeah, no, that sounds fantastic, and hopefully, it can be broadened. And just from an aside, I mean, would like to pursue pain management down the line. And I imagine I'll be dealing with a lot of patients, with back surgery that are dealing with issues in the back, whether it's spinal stenosis, whether it's other issues that they have going on. And so I think the whole goal of the medical field would be to try to figure out the best approach we can take to, figure out other medications. And of course, there's always this balance that we have to play with, whether it's bleeding risk, other issues that medications like NSAIDs can have. So that's a lifelong battle for us physicians, different sides of the aisle that me and you are on. So that's all the questions I have. I'd just like to once again reach out to you if you have any other closing remarks that you'd like to get across to the listeners of this podcast.
No, I think we touched on everything that's important here. I think times are changing, and I think people are becoming open to the idea of making some changes as far as trying to get rid of opioids. And I think, for the most part, I think we've made some good, forward steps in that fight. I think my hope with this study was to hopefully change the dogma of what was previously thought that, anybody that had a lumbar fusion, you can't use NSAIDs, you can't use Ketorolac, it's going to kill their fusion, you can't do it. And so if there's any takeaway from this, hopefully, and certainly when, at the completion of this trial, my hope is to change that dogma and move the thought away from that tone.
Mm-hmm. It's fantastic. I think that's a fantastic way to end it. I just want to thank you so much for taking the time. I understand, being a neurosurgery resident is very, very busy, so we really, really do appreciate it. I think it's fantastic that you're in Michigan right now for residency. I went to med school there, and something you mentioned, you grew up in Las Vegas, where I did my transitional year at Southern Hills Hospital in Las Vegas. So we're just connected. It's meant to happen. The podcast between me and you. So that's all the questions I have. Thank you again so much, Dr. Claus. We really appreciate it.
It's my pleasure. Thank you for having me.